Yeah, hello everybody. I'm Renat Akhmerov. I'm inventor of Plasmolifting technology. This technology deals to PRP implementation, and usually we have association here in Russia, in used Soviet Union countries, that plasmolifting is a PRP. Sometimes I can agree with me that plasmolifting and PRP are the same technologies, but I will deliver to you the lecture about plasmolifting, and you will understand. I hope you will understand um, about some differences between plasmolifting and PRP. This is another way of thinking about PRP. Let me introduce myself a little bit deeper. I am geophase and aesthetic surgeon, but I had a good practice in head and neck in field of head and neck surgery in oncology, and I've been doing my practice with plasma with PRP during last 19 years. And so I think that I can give you another point of view about PRP technology. So the first slide, the conceptual framework for implementation of plasmolifting technology. And please, next slide. So usually during my lecture, when I am talking about plasma, I use this slide with connotation. You see the standard phrase, what does it mean, plasmolifting, in physiology, in medicine. At the same time, you see the space. And you see the space. It contains a number of proteolytic cascade systems whose role in the regulation of hemostasis and immune system is essential for the fast, selective, and localized operation of humoral defense in the organism and its control in the vascular system. Please, next slide. And this is a very important thought that I have in my theory and my theoretical background about plasmolifting. Today, most researchers and healthcare professionals intend to regard plasma in the in the context of its therapeutic use as just another official preparation. In contrast, I am inclined to believe that procedures involving blood plasma are similar to the transplantation of autologous blood tissues. It depends on your way of thinking about what does it mean blood inside of us. We have to know that blood is an organ or the tissue, but not official drug, not official medicine. And when you think about plasma as an organ, as a tissue, you have to think about autologous transplantation. And it will solve all clinic situation in your practice. Please, next slide. Of course, we talk about platelets, and everybody in PRP, in the field of PRP, discusses platelets. Of course, platelets play the great role. Platelets are a component of blood, which, along with leukocytes, blood white cells, contributes to hemostasis and plays a crucial role in tissue regeneration. Furthermore, platelet proteins have been reported to exhibit antibacterial, analgesic, and anti-inflammatory properties. Please, next slide. Platelets are involved in complex interactions about the formed elements of blood. And existing evidence suggests that the mechanisms of interaction of the elements of blood in general and those of plasma in particular are still only partially understood. Therefore, I am of the firm conviction that the roles of the other components of plasma, such as, and please pay attention here, cytokines, growth factors, macronutrients, macronutrients and micronutrients in complex biological processes should not be disregarded. It's very important. In blood, in our plasma, we have everything that we need to make therapeutic effect. It's evident that all processes in blood plasma and exposed body tissues are multifaceted. Please, next slide. And usually I use this symbol in order to show us how does it work. The interaction of blood plasma components and the resultant synergistic effect can be compared to the eternal unity of all things represented by the symbol of Ouroboros. All, one is the all is one is all. The next slide, please. And I'm accomplishing the romantic part of my lecture. Here you can see the connotation, visual connotation, when we see the planets, stars, our sun, and the name of some players inside of our plasma. So please, next slide. And the results of attempts to single out particular elements of cellular and other biological responses seem controversial and have not been corroborated in practice. All the beneficial and clinically important characteristics of blood plasma are preserved irrespective of various protocols and methods of its preparation. On the right side, you can see some abbreviations that my colleagues use in the world, and they use PRF, PRGF, APRF, etc. But all these, the names are similar from my point of view and from the point of view of my colleagues. Next slide, please. Autologous plasma therapy involves the injection of the native plasma into tissues. That's very simple. But it's used to initiate regenerative processes, especially in aesthetic medicine, to treat muscle spasms, to produce analgesic effects in rehabilitation, in traumatology, in neurology, of course, anti-inflammatory and antibacterial effects, and to serve a prosthetic function. For example, I can use the example of the treatment of knees, of arthrosis. Moreover, I postulate that the injection of blood plasma mimics, it's a very important thought for me, mimics the pathophysiological processes involved in the bruise formation. When we make injection of plasma, we produce the mimicry of the bruise, not hematoma, the bruise. This is a stress, of course. This is a stress for the tissue. Next slide, please. Wow. And now you see the slide which shows us what we have inside of lesion, inside of trauma. We have fracture, we have rupture of vessels, and we have bruise. This is very simple. And the next slide, consequently, we have a stress. We have a stress and we produce stress, the small stress, very useful, but stress for our tissue. And here in Russia, I deliver a lot of lectures, not only standard lectures, about the prophylaxis of our immune system against coronavirus. And this is very simple. When we make the stress by autologous plasma injection, we can improve our immune system. This is a very simple, and it takes the source from autochemotherapy. So the injection of autologous plasma induces tissue stress. The next slide, please. According to our knowledge from the medical school, we know that human being body needs every time stress. And the creator of this theory, Gansillier, and we know him, of course, and the chronologist and stress researcher, has defined stress as a non-specific response of the body to any demand made on it. According to him, stress is unavoidable, and in fact, it would be the undesirable to avoid it. I have often said that stress is the spice of life. It can be a great stimulus to achievement. In other words, stress is necessary and even beneficial for life. In this way works plasma. Next slide, please. In our practice, every time we need history as a background of safety of our technologies. This is very important for practitioners. We have to know that this method is very, very safe. The safest method, as I know, in medicine. Max Schede, he was a German doctor, he was a surgeon, and he lived and worked 160 years ago. And he was the first surgeon who revealed, who found that the small blood helps for the lesion to be recovered. And he was the first, and he called it in German Hemoplamp. It wasn't the term or autohemotherapy. The next slide, please. And there are many very famous doctors who supported autohemotherapy as a method of treatment before antibiotics era. But the very important was for us Paul Raveau, a French doctor who gave the name autohemotherapy. But also I have to emphasize that in the United States, there were a lot of doctors, two doctors from Sweden, Elfström and Grafström. They treated pneumonia, they treated pneumonitis after tuberculosis. Gilbert, Beer, Jeff Spithoff in England, all over the world, people used autohemotherapy very successfully. And the next slide, please. Perhaps in part due to the lack of universally accepted explanation, we hadn't explanation for the reported beneficial effects of autohemotherapy, and certainly in part as a consequence of the advent of antibiotics, vaccines, and other pharmaceuticals, the interest in classical autohemotherapy has declined and virtually disappeared. So, and moreover, usually I add one thought during my lecture. When we used autohemotherapy, there were not any benefits for doctors, for pharmaceutical companies, and for anyone. That it was not priceless, but the prices for autohemotherapy were very, very low. This is a reason that we didn't use, spreadly didn't use autohemotherapy. And of course, autohemotherapy was very, very painful. And some doctors used 100 years ago the first type of narcosis. For example, the very great Russian surgeon Voyno Yesenecky, Professor Voyno Yesenecky, described his experience with treatment of furuncles, carbuncles, other Bruce conditions, and he used Rauschen narcosis, so like a shocked narcosis. And the next slide, please. From our course of biochemistry, from the medical school, we remember that blood consists of three parts. In our tube, we see in upper part plasma, of course, red cells, and in the middle, we see the platelets, monocytes, lymphocytes, and as an English term of it is a Buffy code. You should remember this term from our medical course. And of course, this is a biochemical point of view for the plasma implementation. You can see here the platelets, monocytes, lymphocytes. That's a very interesting for me to describe some aspects of plasmolifting, of plasma implementation from this slide. For example, you see platelets. Of course, we use platelets. Monocytes, non-specific immune response. We have plus 20% of monocytes every time, just after 3-4 days after plasma procedures. And of course, lymphocytes that we use, of course, also in our technology. I mean PRP. Any type of tubes, any type of treatment are equal. Differs are only in protocols, in your knowledge about PRP plasma implementation. So the first spin separates the red blood cells from the plasma, which contains the platelets, the white blood cells, and the clotting factors. And of course, in order to escape coagulation, we use anticoagulant. In Europe, we use, plasmolifting technology, we use citrate. In Russia, we use here heparin. I think that there is no difference in therapeutic effect between heparin and citrate, of course. And but according to legislation, we must use citrate in Europe, in the United States too. The next slide, please. Here, this is a history of PRP. In the published works of Robert Marks and Hennes Ward, it's postulated that PRP platelet count of 1 million as a measured in the standard 6 million aliquot has become the benchmark for the therapeutic PRP. But this work was based on some revealing of new knowledge in case of plasmolifting of plasma, that world medicine understood that platelets have growth factors. And Robert Marks suggested with colleagues to make the compilation of growth factors. Initially, the term PRP was preferred to autologous platelet gel, and the true PRP doesn't meet injectable form, only the gel variant, that Buffy code that we call Buffy, but that we call and that we know the term Buffy code, plasma-rich growth factors, or a mere autologous platelet concentrate that may be mixed into a bone graft. It was widely spread in dentistry. Layer it in as the graft is placed, spray it on a soft tissue surface. 20 years ago, I, with my colleagues, we suggested to use the simple variant of PRP, injectable variant of PRP, that now we use everywhere. And I can explain to ourselves that what does it mean plasma now, what does it mean plasmolifting now and PRP now. It's something middle between autochemotherapy and true first variant of PRP. the injectable variant as we had in auto chemotherapy, at the same time without red blood cells, erythrocytes. And the next slide, please. And a very important thing for us to understand why we don't pay attention for the concentration of platelets, why it doesn't matter for us. It's very simple. At present, the advisability of applications of the above-mentioned protocol seems to be questionable, taking into account that up to 100 milliliters of blood must be drawn to obtain true a plasma preparation with a platelet count of about 1 million. But do we need it? A double centrifugation technique is in the labor and time-consuming. The true PRP needs double centrifugation. A significant loss of platelets occurs in the laboratory, of course. This technique is only available to specialists. I must say that was only available to specialists in various types of surgery. Now, usually, I didn't see during last 5 years that anybody didn't use real, true first variant of PRP, who used 100 milliliters of blood, firstly, double centrifugation, and only after surgery, because they used gel, and of course you can introduce gel only after incision. The next slide, please. But the key to understand of this problem, of this issue, is very, very simple and lies in our course in middle school, physical course, the course in physics. While according to the formula, mass is equal volumetric concentration, volume and concentration, the platelet concentration and saturation of the tissue can be increased just by increasing the volume. In other words, I want to explain you, this is very simple for me. You can compare with the milk concentration or alcohol concentrations or any type of drugs concentration. If you will increase the volume, you automatically, consequently, you will increase the concentrations of platelets. That's why we can concentrate platelets not in vitro but in vivo, just by the pushing to the syringe. You can increase the volume in your practice. It's very, very simple. But at the same time, you will saturate the quantity of platelets. The question of platelet concentrations must be solved by this very simple technique. And I don't know why nobody pays attention for it. Nobody paid attention for it. I deliver the lectures every time, everywhere, and I don't understand why people don't understand this very simple thing. The next slide, please. Notwithstanding the evident advantages, as I said, of applying injectable preparation and use in a single centrifugation technique, the subject of platelet count is still being debated in publications. This is probably due to the strong association of the term PRP. But I think that we will use this term PRP because people understands what does it mean, especially doctors. They remember what does it mean PRP. It means now only the plasma implementation. The next slide. This question now is not actual for us, but I have slide about it. This question, the same goes for the debates about platelet activation, as well as about the necessity of adding calcium in order to activate platelets. We don't do it, we didn't do it, and there is no evidence why we need it. But some of doctors insisted about the adding of calcium. Adding of calcium is relevant to platelet and concentrates, but not to injectable preference. So usually to my students, to my doctors, I tell that that in plasma, every time, everywhere, we have very good, very strong, very permanent level of calcium, and calcium is very active there. So that's why we don't need adding any type of calcium. The next slide, please. What do we mean by platelet activation? But usually this is a normal notion from the pathology, from the physiological and pathophysiological viewpoints. This step is a normal platelet response to removal or injury of the endothelium and to contact with subendothelial structures. Simply, when platelets loses the contact with endothelium, it's activated. The next slide. And now on the next slide, you see how can be activated, must be activated every time. Platelets and other part of plasma must be activated in our practice. And the next slide, please. Growth factors. Of course, my colleagues usually insist about the importance of growth factors. So, and you can see here some type of growth factors, epidermal growth factors, platelet-derived growth factor. There are a lot of growth factors that we know, and probably there are a lot of growth factors that we don't know. I mean, they're fundamental medicine. The next slide. So the platelets may be activated by any environmental perturbation, including mechanical stress. The most important physiological stimuli for the platelet activations are collagen, thrombin, ADP, and thromboxane. Upon activation, the platelets gain their capacity of adhere to the injury site, platelet adhesion, and to interact with the ligands, platelet aggregation, forming a hemostatic plug. Moreover, the platelets participate in the activation of the coagulation cascade through various pathways, including exposure of procoagulant membrane, phospholipids, and secretion of alpha granules. The next slide. What is the role of calcium in plasma? Of course, calcium plays the great role. But as I told you that we have plasma and we have enough and we have very good level of plasma normally in plasma, and we don't need any type of addition of calcium. The next slide, please. We discussed it. So this is an article that I did with my colleagues 17 years ago, and we suggested first. I don't insist that we were the first doctors, because this is a very simple for me. But we suggested not to use gel variant of PRP, but injectable form. In other words, I want to say that I suggested to make step aside, one step back from PRP, to do it simply. And I want to say that in my practice, in my career, I see the loss of my inventions are a lot of my inventions, sorry, a lot of my inventions are not so complicated, very simple. And so the next slide, please. Next slide. What I wanted to say after my 17 years of practice in this field of plasmolifting. What are the advantages of its use? I mean, injectable form of plasma. Applicability in the areas of medicine that focus on the non-surgical treatment. Before, only surgeons, only dentists used PRP. Potential for use in surgery throughout the perioperative period and even instead of operation. Usually I say to my doctors, to my students, we can use plasmolifting before surgery, after surgery, during surgery, and instead of surgery. And really, some surgeries are not necessary now, and up to 60, up to 50% in traumatology and orthopedics, we can escape surgery. Possibility to increase platelet concentrations in vivo that I told you before. No need for double centrifugations. That's very simple. Possibility to use autologous plasma as a drops treatment for conjunctivitis, as applications, faster recovery after peelings, and laser resurface and treatment for burns and ulcers, as a bath, freezable suppositories, treatment for anal fissures, and even as a powder plasmolifting. 3 years ago, I invented this technology. This is a very simple technology that you can prepare powder, the powder from plasma. You need only 10 minutes and vinyl gloves. Moreover, our technology allows to heat plasma in order to obtain plasma gel. That's the variant of gel implementation. Thermo heat plasma technology. We use it for soft tissue augmentation and contour correction. So the next slide, please. What quality should such tubes have? What should they contain? When I understood that we can use very effectively plasma, I decided to be honest to my colleagues and not to take high prices for tubes. Why? Because all tubes are equal. There is difference, of course, one difference between in vivo and in vitro tubes, but the price differ in price not very high. That's why I insist that we can use cheap, not with very high prices, tubes, and we see in our practice, in our results, that the effectiveness of all tubes, I mean, of course, in vivo tubes, effectivenesses are the same. Please, the next slide. But we have legislation, of course. Now I'm talking in English, and I understand that most of my the audience live in Europe, in Great Britain, and we understand that we have to be inside of law. And there is a regulation in European community and other countries, for example, in the United States. According to qualification, we need 2B or 2A. And here you can see the explanation and the summary from the part of legislation which describes the regulation of it. And at the end of this slide, you can read The minimum effective dose of autologous plasma obtained by using the plasmolifting technology is 3-4 milliliter per 1 square centimeters. It's important for cosmetologists, for aesthetic, for specialists in the field of aesthetic, of the skin surface, of course, or cubic centimeters for soft tissues. And each milliliter of the minimum effective dose contains, you see, 300 millions activated platelets. It's not 1 million per micromilliliter, but that's enough for therapeutic effects. And of course, if you wanted to just to concentrate, to increase the quantity of platelets, you can easily do it only by increasing of volume, as we discussed before. The next slide, please. With Anticoagulant To Use, I told before that we use heparin and use citrate in European countries, in Great Britain, in the United States, in Great Britain and in the United States, we use, of course, citrate. That's okay. There is no differences. There are no differences, but I use citrate, of course. The next slide, please. Tube walls. Sometimes you hear that we have very good tubes because of plastic, because plastic doesn't make any influence for platelets. That's very stupid. Of course, doesn't make. But some of my colleagues insist that we have to use the glass. Of course, glass is very good and obtainable, but there is no big difference. In Europe, in my technology, we use glass, of course, and I insist that glass is better than plastic, but there is no great difference. Please, next slide. How should autologous blood plasma be administered? This is very great and very important questions. And currently there is a number of modes of autologous blood plasma administration: application, infusion, inhalation, rectal, oral, and during our classes, we deliver any type of successful protocols. But before protocols, please remember that we don't make the injection or implementation of a fictional drug, a fictional pills of injection. We use autologous tissue transplantation. And first principle, if you know principle, sometimes you can escape some details. The very, very famous phrase in philosophy. It's based on the fact that the region of the highest concentration of growth factors coincides with the plasma injection site. In other words, in the needle penetration site, the growth factors comes into contact with the specific acceptor protein in tissues. As example, I want to say that for aesthetic doctors, I tell them, please pay attention that you need to achieve, by the point of your needle, the exact place that you need. There will be the contact with growth factors and the receptor to growth factors. So, for example, if you need make regeneration of periosteum, you must to be there in periosteum. It depends on your technical abilities, but it's easy for good practitioner, of course. But you know the first principle. What is the second principle? Let's go there. Please, next slide. The second principle is very important for traumatologists, for neurologists, and of course for dentists, the principle of plasma envelope. I tried to find a very close term for in English, but in Russia we say in Russian we say the so it's the pocket, the therapeutic pocket for consistent in wrapping in an organ of tissue subjected to treatment. For example, you can see here the ulcer, and according to this principle, you should make injection around the ulcer, upon, and beneath. So, like according to the principle of autologous transplantations, if you will think. You should think as a surgeon who makes autologous plasma transplantation, autologous organ transplantations, and you will see the most successful effect. Okay, the next slide, please. There are various treatment regimens involving the use of autologous plasma. Of course, there are a lot of, and you can read here, while responses to treatment vary, the desired therapeutic outcome may be achieved either after just, of course, the beginners of PRP technology sometimes see the very good results, sometimes not to see, and they ask themselves that, well, I don't understand. Sometimes it works, sometimes it doesn't work. Why is such a difference? The next slide, please. How many treatments? In my opinion, for instance, in my opinion, the key lies in the biological response rate of body tissue. And you can read now, but I can give you the simple explanation. Sorry. For instance, mucosal responses to the treatment are rapid. In contrast, skin responds slowly. Nevertheless, whatever the medical condition, tissue responses may be observed in 1-2 days following the treatment with autologous plasma. Its therapeutic effects can last for more than 1 year, with the exception of for skin and its appendages. The skin and its appendages are very, very lazy tissue from the point of biological response. And the skin function itself doesn't allow for rapid tissue responses. We can observe it while using autologous plasma for cosmetic therapy. And a healthcare professional confident of getting successful therapeutic outcomes in autologous plasma therapy must inform the patient about the slow and gradual onset of therapeutic effects produced by plasma. So, and sometimes I use this phrase, we have to use principle of quantum satis. We do plasma till the achievement of result. So the next slide. Next slide, you can remember, you should remember the rate of autologous blood plasma administration and the total duration of treatment vary also with treatment goals. It's, of course, it's based only on our clinical experience. And we recommend, I recommend to you the following therapeutic sequences to obtain an anti-inflammatory effects. For example, in case of treatment of acne, 2 treatments spaced 2 weeks apart. But please don't forget that acne basically has 2 reasons. The first reason, the physiological low level of immune response, and the second reason is a hormonal disorder. Of course, in case of hormonal disorder, we need the support treatment of hormonal support treatment. to obtain the pro-inflammatory effects in case of initial situation of inflammation, and single dosing is enough. To obtain any antispastic relaxing effect, single dosing is enough. That's very important for doctors who work in field of rehabilitation. For the tissue healing, 2 treatments space and 2 days. For the tissue regeneration, it's very important for aesthetic doctors. And to obtain a functional recovery, that's important for example, for orthopedic specialists. Please, next slide. So, in what areas of medicine is plasmolifting technology used? Now we have a great plenty of knowledge. As for me, I think so. But branches of technology: plasmolifting gel, icicles, freezable suppositories for the rectal disorders, plasmolifting skin cream, plasmolifting powder, dentistry, native plasma, plasma gel, and thermocrepes. It's very interesting, and there are a lot of benefits for dentists: trichology, aesthetic, gynecology, urology, proctology, general surgery, dermatology, everywhere. And of course, in veterinary medicine. If you will be interested in the next step of plasmolifting, we can deliver it to you some video courses or some online, and I hope very soon offline education in Great Britain, in Europe. And the next slide, and I'm accomplishing there my part of theoretical background. The next step, the next will be practice and results. But what are our tasks? Looking for a rule, of course, that no doubt exists. This is a live technology, and we have to improve it every time. A healthcare professional must have a clear idea about the frequency and regimen. Of course, we improve our technology every time, and we pay attention, especially for the renovation of our protocols. Then next slide, please. And we are thinking about creating new forms of autologous blood plasma. And we are thinking about making autologous blood plasma injections a routine, effective and safe method of biological simulation. So the next slide, please. The results of applying plasmolifting technology, and you can see if we are beginning from the dentistry. Please, next slide. So you can see the charms, single dosing of autologous plasma, before treatment and after treatment. And the next slide, please. Single dosing of autologous plasma. If you are not dentists, maybe you can be confused by this color. This is a iodine. The standard tests to measure the level of inflammation. It's very understandable for dentists. The next slide, please. And in dentistry, in case of gingivitis, that's a very, very clear for us, everything. So the next slide, trichology. Sometimes you can see and you can achieve these dramatic results with the alopecia areata. The next slide. This is a second slide. No, next slide. This is a alopecia areata 2 circumscripta. The next slide. And my textbook about PRP and my textbook about plasmolifting, of course, I have to confirm by immunohistology. This is an immunohistology confirmation and approval of our effectiveness. The next slide, please. The next slide is next slide. And next slide, please. Immunohistochemical analysis. The next slide, please. Again. And next slide. Next slide is more interesting for practitioners. Type of inflammation, staphyloderma and streptococcal impetigo. And after single application of autologous plasma, you can see this is not real. It looks not real, but this is a reality. And sometimes you can see the magic moment of plasma effectiveness. The next slide, please. Psoriasis. Psoriasis in PRP, we are not sure about exact protocols, but sometimes you can see the very good results. In the next slide, please. Next slide, please. It was I was wondering when my doctor told me 10 years ago that he got good results in treatment of plantar routes, and now I administrate only plasma without surgery in the same cases. The next slide, please. You can see before and after. Eczema. Eczema, of course, we don't say that we solved this problem, of course, but approximately 90-95% of the good results I can guarantee. I can guarantee to you. The next slide, please. Our results and our first experience 5 years ago in case of the nail treatment onychodystrophy. It was inflammation and disorder out of fungal inflammation, but you can use during the normal onychodystrophy, I mean the fungal infection, of course you can use it. The next slide. The hand eczema 2, the case with our nurse. And the next slide. This is very important, and this is a very famous case because this is my right leg, and I will not show you my leg now, but of course I can do it. But during my lecture, usually I demonstrate my right leg, and I hope that I will visit you soon. Maybe in summer, maybe in autumn, and I will show you my leg. What does it mean here? Then when you will use plasma PRP successfully on your body, with your relatives, and you will see the very good results, you will become the very true PRP plasmolifting. You will be very lift up. So the next slide, please. Sometimes it's like a freaking out for us. I mean, the results in field of PRP. So age-related atrophic changes in the skin. Yeah, this is a routine for us now. The next slide for aesthetics. That's a very interesting case. The next slide. I prefer to use my old cases and the cases of my doctors before and after treatment. Of course, you can see fibrosis and inflammation. Here you can read the regime hard. Hard, it means the regime very often hard. It's for example, during 1 week, two procedures during 1 week, apart 6 days. But usually I insist for the period between injection 2 weeks. The next slide, please. I was wondered when we got the first results, it was 10 years ago, in case of treatment of cellulitis. That's a routine for us now. The next slide. Cellulite, of course. And the next slide will show you how can we treat by plasma in combustiology department, burn injury medicine. Now you see the patient after the burn injury, and it was by the flame, and we used plasma on other part of body, and another part of body was treated without plasma. The next slide. You can see the control wound on the left hand and the test wound. Test wound means with plasma. The next slide. 10 days after the illness, the second, next slide, please. 17th day. And you can see the difference, 24 days. And recovering, 36. You see the dramatic difference between without plasma and out of plasma. The next slide, please. Remember, I told you about principle, the second principle, the envelope of wound. Now we see the iteration and the result of treatment. The next slide, please. This is diabetic food. And in the beginning of my practice with plasma, I didn't recommend to use plasma in case of diabetic, but now I insist. And moreover, I want to say that now we are I studied the ability of plasma to treat diabetes, the level of sugar in side of our body. We use intravenous injection of autologous plasma, and we see the very good results in case of diabetic condition and diabetic food. Of course, next slide, please. But here was, of course, only the local injections. Ischemic ulcer. The next slide. And the ulceration, of course. Wound healing, that we call it. So this is the end of my my standard lecture about plasmolifting, my theoretical background, and I had shown to you some of my results and results of my friends and of my colleagues. So if you have any questions, you can write here, or you can write later. I think that we can communicate more often. So, is there? Oh, I want to see chat. Okay. Here is a. Yeah, some greetings from my colleagues. Thank you very much. So sorry for my errors and mistakes in English, because now I'm learning German. It's not easy to me to change from German to English now. Yes, good day, Dr. Akhmerov from Romania. I'm a gynecologist and have been at your training in Julie, Moscow. I remember you, of course, Diana. I have a question about gynecology use of PRP. I use carbon, fractional laser intravaginal. For the mucous, what do you think about using PRP with laser? Of course, I think that this is a very, very good idea to use plasma just after a laser treatment. At the time distance should PRP be done after? Of course. What time? Just after procedure of laser, you can use application of plasma, and you will see the very, very good effect. I think that's enough, because what we do with laser, with laser we do under control, of course, but small burning, and we can use plasma as for recovering, for fast recovering of the area of treatment. And O shot, G shot, or regional Ross injection for additional help in atrophy. Of course, we had and we have very great results in field of plasma. I don't remember exactly, but probably you were trained, Diana, by our doctor from Yekaterinburg, Ivan and Cibula, his name Ivan Cibula, and I think that he's very, very good, skilled in field of treatment. I think that I will now we are doing the translation of our video courses, and I think that we will finish our video courses in May in cosmetology. In June and July, I hope we will accomplish the translation of our courses in sexology. And I hope that we will send you our video courses, or we'll be happy to see you here in Moscow, or I can give you my words that I can attend Romania too. With great information. Thank you very much. Yeah, of course, I understand, Diana. Some say it's not recommended exactly after laser. I had shown you to you that PRP has a very, very good anti-inflammatory and recovering effect. And you can use the plasma as a application without, of course, injection just after the laser. Do not hesitate. Don't any doubts of it. You remember Ivan and Olga. Okay, would you like to visit you? Thank you very much, plastic surgeon. Thank you very much, Paul. Yes, I will be happy to see you in London, and of course, we will be happy to see you in Moscow too, or in Frankfurt am Main. Sometimes I work in Frankfurt in Germany and in Moscow. Thank you. So thank you very much, dear colleagues, dear doctors. It was a great pleasure for me to see you, to hear you, to communicate with you, and I hope next time it will be very, very helpful for us. Thank you very much. Bye.